This is going to be more, I hope, a conversation than it is a presentation. I did prepare a couple of things just to kind of set the context, but then am really here to engage all of you. You're all respective experts in your respective fields. And so I'm very interested in your thoughts on what we're trying to do. So I mentioned I am co-founder and CEO of a technology platform called Wellbly Technologies that is focused on improving patient engagement and specifically trying to make medical billing easier for patients to understand and simpler to pay from wherever and however consumers choose. And when I talk about that flexibility, that encompasses payment plans, that encompasses providing patients visibility to how much of their, if they've got a high deductible plan, how much of their deductible they may have left to spend, whether they choose to pay a particular bill through the cash portion of their HSA and the remainder through other means. That aspect of the patient journey is really where we're trying to focus. So I prepared a couple of things. I think you probably have, I think Jim, you may have circulated some of this stuff. So let me just, and again, these were more set up for conversation and less about necessarily putting forth a specific solution per se. Just a little bit more about Wellbly. We're a mighty team of four, myself and my co-founder, Costa Hajidimitriou. I'm based in New York. He's based happens to be actually in Toronto and Texas. And we have worked together for a number of years on B2B technology solutions. Specifically, we worked together at Royal Bank of Canada building a business solution for cash management and money movement for businesses, which included healthcare. So Costa is our head of product, has deep payments expertise. My background, I described finance, but also customer engagement platform. So I was the chief experience officer at a Fortune 500 wealth management company before I left to start Wellbly. So let's get started. Again, let me go through a couple of these things and set the tone. And then I'm just really interested in particularly the folks who are practitioners themselves or work directly with practitioner, where they land on some of these things. I want to talk today with you about price transparency. Obviously, we know this has been a movement underway for a very long time, but has gained further momentum most recently with, for example, the hospital price transparency rule in effect this year, and further actions requiring payers, employer plans, and frankly, providers. At the end of the day, patients are holding providers accountable for providing billing and cost information and helping them to understand these things. We interviewed a number of independent practitioners across the country, and this individual, who happens to be based in Portland, shared with us that once upon a time, he said, I had considered providing our patients price information in advance as a professional courtesy, but now I see it increasingly as table stakes. When we asked him how much of his time or resources are spent actually doing this, he shared that 25 to 30% actually of his front office staff's time goes to providing patients a cost estimate as well as payment processing. I spoke with the VP of digital patient experience at a large hospital based in New York yesterday. And she also shared with me that this is a significant expense pool, specifically calls coming into their call center about medical billing and processing payment. In some of her patient journey work, her team actually went into patients' homes to ask and understand what that patient journey looks like specifically from on the financial elements of care. And she shared with me that one of the patients they interviewed were using their oven as filing storage for all their EOBs, their explanation of benefits, and the provider um, provided patient statements, and that they were kind of tearing their hair out trying to reconcile these things and figure out what they needed to pay, and were kind of going back and forth between the provider and the payer to figure it out. Um, Personally, coming from a financial wellness standpoint, I myself was a financial advisor for a number of years. Um, I think as our system moves more and more to one where we as healthcare consumers are expected to be responsible for care, in partnership, obviously, with our providers, it's going to be really interesting to see, how consumers are able to understand cost information and figure out how to make these decisions that affect their household budget. So that's what I want to talk to you all today about. I've got a couple more things I want to show you, and then have formulated from some discussion questions. But before I go any further, does anyone have any questions or comments? Okay, great. I'll keep going then. One of the other tidbits that the executive shared with me from the hospital about cost, she said that hospitals spend on average $13.70 per transaction when a patient calls their call center, versus less than $2 to process that payment digitally when it's a self-pay transaction. So just to give a sense of and for those of providers on the line, obviously, or who've worked in hospitals, are well versed in this, but really just incredible numbers when thinking about that. I think many of us are well on our way, or understanding that as consumers, whether you have a high deductible plan today or you're an employer, those of us who didn't necessarily start our careers in healthcare, we're all becoming more fluent in healthcare and how to make these choices for ourselves, for our employees, for our families. I pulled this from the CMS landing page, and it'd been a while since I'd been on, and it was kind of struck by their language. Obviously, we're putting patients first. I'm just going to share the bold parts that struck me. We must empower patients to work with their doctors and make healthcare decisions that are best for them. This means giving them meaningful information. I think meaningful is really key here, about quality and cost, to be active healthcare consumers. So again, just accelerating this movement towards more engagement from healthcare consumers. And I think probably, hopefully better solutions out there to help providers and patients make these decisions and understand the care that they need. Very quickly, because I want to move into the discussion, again, I don't think these numbers will be shocking. 86% of healthcare consumers want to know how much they need to pay upfront. 56% would even consider switching providers. I think that really depends on the situation. And 49% of patients who have missed a healthcare payment said they're more likely to pay on time if they have some kind of a flexible payment plan option. In our interviews with providers, I think there's certainly an intent or an interest if they don't already have a payment plan. The question is there technology that can help facilitate that so it doesn't become an administrative or cost burden to that practice? Any questions or comments at this point?
Well, and I would add in that there's a Medvalista family doc that is leaving her clinic to start up her own practice. And she did a gathered a lot of her perfect patients together and said, how can I create a ideal practice that you would refer your friends into? And the number one thing was price transparency. They want to know what it's going to cost now that we're in the world of higher deductibles.
Yeah, no, I think that makes a lot of sense. So I'll just sort of end here, and then we'll get into the discussion. I refer to it as a movement. We know price transparency wasn't something that started with the hospital price transparency rule as of this year. Certainly it's, and I'm very interested in Wade, others, Clint, your thoughts in to what extent do you feel this is something that patients care about, or you feel you have to engage with? Interestingly, as based on our primary and secondary research, consumers are saying they want this information. The actual engagement with the tools that are out there, like, for example, a lot of these estimator tools, whether state provided, like in Massachusetts, or payer provided, have very, very low engagement. So there is something missing between consumers and providers expressing an interest in, yes, I would like to understand this information better, or yes, I would like my patient to understand this better and not have to do this have my front office staff do this, and the tools that are available just not meeting that need. So that's what we're really interested in. I'm delighted to have the chance to talk to all of you today about this. I formulated some questions, but please this doesn't seem like a shy group. I really just want to hear what you all have to say about price transparency broadly. So with that, Jim, I'll kick it off with some of the questions I prepared, but again, really open. Very curious, what are providers' perspectives, or to the extent that you work with providers, if you're not one, with respect to price transparency? How does this impact your practice, if at all?
My firm has done a tremendous amount of work in this area. I could probably spend hours talking about this subject, from both the hospital side and the clinic physician side. There's the biggest challenge, or one of the biggest challenges, is defining what is cost to the consumer. So, for instance, with all the hospital transparency rules, you have hospitals that are publishing their list price, and their list price, when it comes to an adjudicated claim, in many cases is kind of meaningless. What's really important is what is the allowed contract rate between the payer and the provider, number one. And then number two is, when it comes to the patient, where are they in their copay and deductible life cycle? And that's always been the challenge. So, not to sound disparaging, but you get a lot of these people that are, that receive these calls, and they're, lower hourly paid people that are answering the phone, and they may be able to look at a charge master and give a price for a CPT code, but it has nothing to do with what ultimately that patient is going to pay. And that's true in a clinic office as well. So, those are some of the challenges. And then, so I'm kind of curious what your group is trying to do in that arena.
Thank you. It is really interesting, and I think right now, so where we've been really focused is on independent private practitioners who are trying to certainly enhance the patient experience, but remove some of that administrative burden from their front office staff. But, Peter, to your point, I have had the opportunity to speak with a few executives at hospitals and have been really amazed by the size of that expense pool that goes to, whether that's answering those questions, or, collections, or managing that revenue cycle. So, yeah, I mean, I'm interested in your thoughts on how are some of your clients addressing that, and do they see clarity or providing more clarity around medical billing as a way to shrink some of the expense pool related to administration? Do they see, like, is that an actual strategic driver that they're allocating resources to support?
Well, they're allocating resources for a couple of reasons. One, it's, yeah, it's strategic and it's very important from a customer service perspective. Two, there's a compliance requirement that is, that's in place and it's being interpreted in different ways. But so some of the tools, for instance, and this is not just hospitals, but also on the clinic side, so that somebody is exiting an appointment in a physician office and told they need to come back for a procedure or schedule a procedure. They want to know what it costs. Certainly there's a very, we implemented with one of our clients over the last couple of years a very complex module in Epic to do that. That in order to be able to give price quotes, the first thing you have to do is basically have a system in place that can essentially adjudicate everybody's claim prior to the insurance company to figure out, what their cost is going to be, what their copay and deductibles are, et cetera. So it can be it can be complex. I mean, it's, that's what I see a lot of my clients struggling with right now. I do have a client though that has, I don't know if you've heard of a company called VisiPay, but they've been very successful in this arena, and they essentially came out of the credit card industry and said, guys, their whole focus previously was people having, just paying their normal credit cards and the complexity around that and figuring out where your credit risks are, et cetera. Well, they took that to healthcare and have implemented tools that make it very easy to pay and how do they pay, and what sources, is it an HSA, is it, et cetera. And that's been really, really well received in the hospitals, clients that I have that have implemented that. We've actually worked, we know the founder of that well, and it's done well.
We've got about 8 minutes left, so I want to give you the opportunity to leave on time, and I'm going to stay around if anyone wants to stay around and chat. But also, Wade and Clint want you to weigh in before it gets too late as to what you're doing, and any advice for our new buddy Cory as she's trying to unravel this. Go ahead, Clint.
Jim. Thanks, Jim. And can you hear me okay?
Yeah. And what's the score, Clint?
1-0 second period. So so sorry here if you hear some yelling in the background, but yeah, if you can create a solution for the multiple layers of complexity in this space, you've got something going. And I think Peter hit the nail on the head. There's price and there's cost. And the problem, both on an outpatient and inpatient setting, is it's very hard to determine what the price is for a service, right? You get a hip surgery, awesome surgeon, and it's $20K, and you go down the block and it's an awesome surgeon and it's $70K. Surgeons are getting paid the same, and there's an admin fee the hospital's taking. So we kind of made it our business for our patients to say, hey, we want to do no harm to you medically, and we want to take that a step further and try and do no harm to your pocketbook, because procedures and visits to specialists, et cetera, don't happen, without an order from a doctor. So it's time that us doctors try and say, okay, if we're going to write an order for an echo or a vasectomy or an order for lisinopril, what's the cost? And can we help the patient in that front? So what we've done is said, hey, we're going to make it easy on the primary care side. Pay us a fixed monthly fee. We will bill you or your employer, and the employer pays us. There's hardly any accounts receivable. Super simple model. That's direct primary care in a nutshell. And then we said, okay, we're going to go to our radiology friends, our lab friends, our ancillary service provider friends, behavioral health, physical therapy, et cetera, et cetera. And we're going to say, hey guys, if our patients or their employer pay you directly with their own funds or their HSA or HRA money, what would the cost be And it's impressive because the CT scan goes to $300 versus 3,000. MRI goes to 400 and a quarter versus 2,000, right? The problem is most Americans are walking around with an insurance card that is purposefully complex. And there are, 300,000 people working for United Healthcare that need to get paid. And so the layers of administration that you put in between the service and the payment, we found that the more and more layers, the more and more complexities and costs. So we are just trying to make that very, very simple with direct pay relationships. It's one thing if you're getting stuff in a hospital and needing an ICU stay. It's another thing if you're getting your gallbladder removed or getting a vasectomy, right? So in our kind of lens, payment doesn't come so much from what is proverbially called the payers, the BUCAs, Blue Cross, United, Cigna, Anthem, Humana. Payment comes from a patient or an employer. And 50% of Americans are walking around with a high deductible. And so essentially they're self-funded. And so we really try to take appropriate steps to help the patient navigate. And there's no app in the world right now that I'm aware of that can help the patient navigate like their primary care physician.
Thanks, Clint. Wade, what are you doing at Capstone about this?
Yeah, we're doing the same thing. I mean, that's part of the reason that we bought, started an imaging center and a pharmacy and lab and things is that we have then control and we can be more transparent, provide better value. I totally echo what Clint is saying from the outpatient standpoint. It really needs to be between the doctor and the patient. That's where your price comes from. And then at the end, only the doctor and the patient can come to an agreement on what that price should be. Hospitalization is a completely different thing, but anything outpatient should be probably pretty much established at the doctor's office. They should know the costs when they're recommending it to the patient. And the patient can then make the decisions on what they want using that information. But as soon as you involve insurance in the whole process and all they have is a $20 copay, their interest level goes down dramatically and they just don't have time for it, right? It's not worth their time to search out who's the best, or not the best, but the cheapest or most value added service when it only costs them $20 no matter where they go. So I think as soon as you take the insurance layer out of it and you make patients responsible for the initial cost of their care, you're going to see a dramatic increase in utilization of your services. And that's why a lot of these state and insurance-based tools, they're not accurate for one thing, but the other is that those folks that have those types of insurance, it's not worth their $20 of time to search that out. But my patients who have these Christian health ministries sharing, cost sharing services, they're always right on it for exactly what the cost is for each thing they do. They pay the bill up front and then get reimbursed, they hope, which they almost always do, which is great. But they're very involved in the cost of their healthcare and the value. So that's where, as a country, that's where our system needs to go. We need to put it back into the hands of the docs and the patients. And as soon as that happens, the costs of healthcare in the country will go down dramatically. Solving the hospital issue is a little different because there's so many variables that go into a hospitalization for an acute illness. But any of the scheduled elective, especially outpatient services, that should be a no-brainer. But it needs to be done at the physician and at the patient level. Hard to do on a statewide level because there's just so many variables in what needs to be done for any given patient.
Thank you. That's very helpful. Are providers, last question, Jim, and then I'll give it back. Are providers reluctant at all? Or when they are, why do you think they may be reluctant to engage in that conversation or provide that information?
Some are uncomfortable. I believe those that have not been in a system where they are in private practice, they're going to be more uncomfortable if they've been employed by the government or the Indian Health Service or TRICARE or whatever, or the VA. They're going to have a harder time because they don't have a full understanding of the economics. But those of us that are in private practice who know what our bills are, who know what the value of our service is, if you're not comfortable with that, you're probably in the wrong business. And I tell my patients and my docs that I employ, When you talk about price, it makes the conversation very honest. You know that they're coming to see you for a value that you're going to add to their life, and your time is valuable, and you're going to provide a better service because of that. So you shouldn't be afraid of it if you're doing a good, high quality job. And so we're very proud to stand in that sort of free market space and compete. It keeps us very, very sharp, and because of that, that's why we're succeeding, is that we understand the value of patients' time and money and what our service is.
Thank you. Very helpful.
Well, and Medvale's working with AID, Association of Independent Doctors, that I'm going to introduce Cory to, and they say this is a godsend for independent doctors because you've got a real leg up as you're competing with the hospital employed physicians for some of the same services.
Yeah.
Clint, go ahead.
I just was going to, number one, echo Wade's comments. And then number two, Cory, you asked, are providers or physicians comfortable? It's one thing if they're comfortable, but one of the main things here is they just don't have the time. So whether you're in an FQHC or you're an employed doc working for a huge system as a primary care physician, you're seeing 30-some patients a day, right? And you're seeing a patient every 10 to 15 minutes. And that churn, you're just trying to get through your day. And when it comes to ordering an echo, you don't care so much which imaging center, as long as they can get them in, give or take. And you're not even thinking really about pricing because you have no clue what tool the patient is using as they can't come in, right? They may have a self-funded employed plan with a PPO, or they may have a Christian health share. It's hard to say, and you don't know. That communication from front desk to doctor, and then when the order is actually placed, it's very complex and challenging, and docs just don't have the time to do it. And that, again, doesn't mean they don't care, but they're debating a bit with, gosh, what am I going to do for this patient's diabetes versus, what's the cost of the echo going to be? And they're oftentimes saying, all right, we want you to do this medical thing, and I'm not sure what the cost will be. I'm going to start you on Triletta. I'm going to start you on an expensive diabetic medication, and then, half patients don't fill it. And the doctor's at kind of an arm's length from that, unfortunately. So couldn't agree more that, it's care doesn't happen without a physician or a provider. And it's important to try and know what the cost and price is, because unfortunately there are too many, let's just say, people in the middle want to protect the status quo, and a fair amount of those companies have a fiduciary responsibility to their stockholders, and that's really challenging in the healthcare arena, right? When you have that fiduciary responsibility to stockholder, and patients are kind of in the mix, or let's say potentially in the way, unfortunately.
Yeah.
I have a quick question. Just as this is not my space, precisely, but I've experienced it just being on the, manufacturing, selling side of it. I guess this is to Clint, Wade, or Peter, is that what's the ideal state then? Are we dealing in an environment that's basically just, a shielded, veiled free market that, how do we get over this hump? Is it just you give all the information, it's publicly available? Like, what do you think are some of the ways around or out of this, if all else equal?
No, it's a good question. It's a tough question. That, as both Wade and Clint described, it's very complex, depending on all the layers in between. So in a perfect world, you'd say, well, it's education and providing information. But I because I do this for, I'm in this space for a living. It's very complex, and I can't imagine how literally 90+% of the population can really understand a lot of how their insurance works and how that translates from the different providers. So that's kind of a non-answer to your question, but it's complex, and I think that the things that are working well, though, that I do see working well, are like Clint's model that he's described, where certain services are covered particularly in a risk environment where the providers are taking risk, and and you're taking out a lot of that middle administrative layer.
Like almost like a retainer, right? Pay a monthly fee for services up to a certain point.
Correct.
Yeah. So it is after past. Keep talking, please. If you won't be impolite though, if you need to stick to our schedule. But stay around and talk. If you don't have a horse you got to go put down or anything like that. Yeah, Cory, how are we doing? You've got other questions there, but
good. I mean, I'll wrap here. I mean, I'd love maybe if, I think Wade, we're going to talk anyway. But Clint, Peter, if you don't mind, if I could, I'd love to get more of your thoughts there, Michael, as well. I think you and I will talk. But yeah, I mean, really sort of digging into this, the approach that we're taking right now is to be, pragmatic, to be humble. I think, Wade, to some of the points that you made about, outpatient, staying away from acute, obviously there are some areas that are going to be more straightforward than others when we think about what is a minimum viable product. But I think really that patient journey and that patient provider relationship has been where we're focused, and this conversation has kind of reinforced that for me. So I appreciate all of your thoughts today.
Mhm.